This module we are going to talk about care at the time of death. So as we think about caring for patients as they're dying, some things that we need to be in tune with. Number one is that family members will always remember the last days, the last hours, and the last minutes of their loved ones' lives. So as nurses, we have a unique opportunity to be invited to spend these precious moments with them and make those moments memorable in a positive way. We can advocate for patient choices, we can bear witness to the events, maintain a presence, participate in interdisciplinary care, and provide support to the family. As we all know, death is a universal reality, but it is a very individualized experience. There is no what we call typical death. So as nurses, we need to come to terms with our own mortality and our own views on loss, dying, and death to be able to maintain presence and to be able to assist with the patient's deaths and make sure that we can help to facilitate a meaningful and positive experience for the patient and for the significant others that are around them. So what does it mean that we as nurses need to come to terms with our own mortality and views? And the way we do this is by having a self-awareness, understanding our self-assessment, and then reflect our own reflections on death. So some things to think about as we go through this module. Think about patients that you've cared for. Have you experienced what could be called a good death? Have you been around a situation where there was a good death? When I look at the picture that's here, I see a woman with her cat at her bedside. She's dying and she's holding her cat, who's probably very, very important to her. This was actually from an article, a news article. And I think, what a nice death this woman must have had to have this comfort in her final days. To some people that might not be comforting, but to myself, I see this as probably was a very good death. Or have you, on the other extreme, seen what's called a bad death, someone who really struggled, who really fought, or maybe the people that person wanted to be there weren't there, or all kinds of different things that could happen. Maybe they had excruciating pain, whether it was physical pain or psychological or spiritual pain. Those of us who've been around death and dying enough have seen both, and hopefully we've seen more good rather than bad deaths. And then think about yourself. What do you, as a nurse, have to offer that is special and unique? Because all of us have our own special talents and gifts, and that's why we do this work of hospice and palliative care. And many times I tell people that it's a calling, because people don't stay in palliative and hospice care unless it's truly something that you feel called to do, and you know that it's a place where you can use your special talents. And then think about your own beliefs of deaths that may have happened within your family, or even difficult patients' deaths. What do you fear about your own death? Because every time that we care for someone who's dying, we kind of internalize little pieces of that and think, gosh, I hope that never happens to me, or gosh, I hope that's the way it would be when I die. So by knowing all of these things, it really helps us be more in tune to our patients and our families. So I want to start off talking about the hierarchy of a dying person's needs. And as you look at this, it kind of looks like the old Maslow's hierarchy of needs, doesn't it? And it is very, very similar to this. So if you look at the very bottom row here, the bottom of the pyramid, it's similar to Maslow's hierarchy of needs. So what are the basic things that our patients need? They need relief from physical symptoms. They need to be free from pain. Those are some of the basic things. And then as we start to relieve those symptoms and treat that, we can move higher up the other hierarchy. So for example, the next one, to be given the opportunity to voice their fears, to trust those that care for them, to feel that they are being told the truth, and to feel secure. And then moving up, to talk, to be listened to with understanding, to be loved, and to share love. These are all part of things that our patients need to experience as they move towards dying. And then more towards the top, once we're coming more to what we almost like Maslow's self-actualization, to maintain respect, in the face of increasing weakness, to maintain independence as long as they possibly can, for even whatever little things that may be, to feel like a normal person, to preserve their personal identity, to be who they are. And at the very top here is to share and to come to terms with the unavoidable future, and really to find out what is the meaning in their death. And once again, this is where it takes the entire team to be able to assess this and address some of these needs. So as we look at the actual death trajectory, what happens as someone dies? And I did put in your additional course materials some teaching sheets from the Hospice and Palliative Nurses Association, and one of them talks about the signs and symptoms that things are worsening with the prognosis, and this is a sheet that you could easily give to family members. So as we talk about the death trajectory, you may hear it called different things. The actively dying is probably personally what I use the most. I'll say they're actively dying. Other people may say imminent death. And really, the progression through these stages can be less than 24 hours, or it could be as long as 2 weeks. But the important thing is to recognize where they're at and what's happening so that we can intervene if we need to. So the first part of early death, or when things start getting worse, is maybe that person who was up and around is now bedbound. They don't want to get out of bed. They have a loss of energy, loss of interest of things that they maybe normally had before. And then you might start to see cognitive changes. And the biggest one that I tell families is they start sleeping more. Once they start sleeping more, it's kind of an indicator that the body is starting to slow down. And then we have the middle phase, and this is where you maybe start to see the obtundation, meaning that they're just kind of there, but they're not really interacting. They're nearing kind of that comatose, in and out. You may start to hear what we call the death rattle or the secretions, because they're not able to clear the secretions. And then the late stages, of course, is the coma, when they're no longer responding. At this point, they may have fever, and that's where you may see some of those breathing changes, the Cheyne-Stokes breathing. The extremities start to get mottled, kind of that purple color. And that's all signs that they're at the late stage of dying, and it could happen fairly soon. So what kind of concerns do we have as the patient begins to progress through the stages of dying? First of all, there's family concerns. And how can we address the concerns of the family? We can best address that by helping families to understand, what's happening, providing education for them, providing reassurance, teaching them to assess whether or not they're in pain, how to look for pain, answering questions about the food and fluids. That's usually one of the big ones. And the way I like to explain it many times is, as the body's starting to shut down, they don't feel hungry and they don't feel thirsty anymore. Talking to them about what they should say. I always tell families to keep talking to them, up until the moment of the death and even afterwards, because the last thing to go is hearing. So telling them to continue to talk to them even if they're not responding back. And throughout this phase, the patient can appear, of course, confused, disoriented. They may see things like they may be speaking to people who have already died, and maybe seeing things, talking about things that are not there, or maybe making out-of-character type statements, gestures, talking about another world of peace or beauty. All of you who've cared for dying patients have probably seen this, what I like to call the near-death experience. We don't really know kind of what happens, but it's important to prepare families for this, because then they will understand that maybe there is some communication with another world or with other people. We don't really know, but typically we tell them just to be there with the patient where they're at, especially if it appears to be a comfortable place. If for some reason it's not a comfortable place, in the example of maybe a war veteran who's in a firefight or something like that, try to reorient them and bring them back. But if they're somewhere where they seem to be comfortable, support them where they're at. because it doesn't always mean that they're hallucinating or confused or having a reaction. It's just part of this dying trajectory. And then think about other things that we have available for the family when we talk about comfort, because comfort is one of the things we want to focus on. Making sure that we know what the goals of care are in the treatment, making sure that we're handling them very respectfully and gently, managing the treatments, assessing for signs and symptoms, teaching the family this. Typically, if the patient is at home on home hospice, they will have, depending on what your facility calls it, an emergency kit or a comfort kit, that they have some emergency medications available. Communication is always key, that we're showing and communicating in a very compassionate way, that we're providing information in simple, clear terms, not using medical jargon. Like I said, providing the education to the family. And sometimes it can be some verbal education, but also leave them a sheet. Depending on your facility, you may have this color maybe known as the blue sheet or the pink sheet. That's a little bit different than other sheets, that really kind of helps them walk them through the changes that are happening as someone's dying. Active listening, making sure that we're listening to what they're saying. And communication with the team members, that we're communicating with the other members of the team that the patient is dying, the patient is actively dying, and that we're communicating that correctly. And then knowledge, as we all know, knowledge is power. Assessing spiritual considerations for the family, psychosocial considerations, treating symptoms as they arise. That's all part of teaching the family. The psychosocial and spiritual considerations that we need to think about, that families and patients are going through, is just the fear of the dying process. Maybe they've never been with somebody as they were dying before. So what do they do? What do they not do? Answering those questions for them. And if they feel comfortable with you, if you've created through your communication that sense of compassion and they know that you're actively listening to them, they will feel more free to tell you what their fears and their concerns are. The fear of the unknown, that near-death awareness, describing what's actually happening if they see that person talking to someone else, and explaining to them what that means. And then, of course, the withdrawal. Sometimes withdrawal happens. Patients may have been very interactive, and now as they start to come more towards death, they withdraw more into themselves, and sometimes that can be a very normal process, and that needs to be explained to family members who may be thinking that something else is going on. Psychosocial considerations, think about how the family is going to cope with this, the comfort of the patient. And then when we think about psychosocial, we also think about what are the final arrangements. Is there a plan in place? Do they want to be cremated? Are they military and they want to have military service? All of these things are things that hopefully we've worked out. They've been on hospice long enough that we've been able to talk about some of these things. And then, of course, the survivor risk for complicated bereavement or just bereavement in general. Think about the physical considerations, and by that I mean those things that are going to happen, those symptoms we're going to have to treat, possibly confusion, delirium. Do we need to treat that, or does it seem like it's something that the patient is comfortable? Weakness and fatigue, many times you see this towards the end, but also sometimes what you'll see is kind of this surge of energy where they've been sleeping quite a bit, and then all of a sudden they have this really amazing day where they were sitting up in the chair most of the day, they were very interactive, and unfortunately sometimes what happens is the family starts to get kind of this sense of false hope if they see that, because sometimes patients just have this rally and they have either this day or this period of time where they do extremely well, and then they kind of go back to where they were and progress to dying from there. So kind of being able to explain that to the family. Drowsiness, sometimes people are very drowsy and just kind of drift off and go to sleep, but unfortunately sometimes other patients have the opposite, where they have this restlessness, agitation. So not everybody has that kind of that peaceful path, and we need to be aware of that, because if they are having the restlessness and agitation, that's where our role as nurses really becomes so important, to make sure that we have the medications available, that we're medicating, and that we're teaching the family how to medicate them. Sometimes patients will have a fever towards the end of life, very common. Typically, we don't treat that unless it appears that it might be making them uncomfortable, but it doesn't necessarily mean they have an infection. Many times there's incontinence, even if they were not incontinent before, and then they may just altogether stop producing urine, and that's a sign that, of course, that the kidneys are failing. And then diarrhea sometimes can occur. Decreased intake, they'll stop eating, and the appetite kind of slowly decreases. Usually within the weeks to days before death, their appetite really decreases. And then as they get even closer, they really do not feel hungry or thirsty at all. Sometimes pain increases, sometimes it decreases. So depending on the patient, they may need more pain medication or they could potentially need pain medication. And then we need to be attuned to their oral secretions. If they're not able to cough up, then you'll start to hear that gurgly sound. And sometimes that's more distressing for the family than it is for the patients. And so we need to be prepared to treat that if need be. So let's move on and talk about symptom management in the next slides. Symptom management is something that we as nurses, that's probably one of our key roles in end-of-life care. And so I briefly discussed previously pain, that sometimes pain increases and sometimes it decreases as the body starts to shut down, because what we know is liver and kidney function are decreased, so therefore the medications aren't being cleared and they can accumulate in the body. And because of this, the accumulation can actually result in hallucinations, myoclonus, and other side effects, so we need to be aware of that. So we need to continuously be assessing and reassessing, looking for pain. Moaning and grimacing, not always indicative of pain, but the one thing that is a good reliable indicator is that furrowing of the brow. That's one of the things that we look at, and then we also teach the patient or the families to look at as an indicator of pain. Also consider that there might be spiritual or emotional pain, and if that's occurring, of course, that's where we need to use our interdisciplinary team. And then in some situations, there may be intractable pain that no matter what we've done, we're unable to control the pain, and this is where palliative sedation may come into play. And then one thing that needs to be addressed with families is that fear of giving the last dose. For example, they gave a dose of morphine and the patient stopped breathing and died 5 minutes later. And you may have to have that conversation with them that it wasn't the morphine that caused them to die. They were treating the pain, they were giving medication for the pain, and it just so happened that that was the period of time. So sometimes we need to do some clarification with that for families. A brief discussion, myoclonus, we talked about that in the previous symptom management chapter, but I did want to bring it up again just to realize that if you do see those jerking type motions as patients as they're dying, that many times it's because of the buildup of the metabolites from the opioids. Once again, they're not clearing through the kidneys and the liver, so we may need to back off on the medications. Sometimes benzodiazepines can be helpful, especially if they're at the end of life. And then if they still are having pain, we need to switch them to a different opioid, once again, depending upon how much time they have left. Sometimes patients can have this restlessness or agitation. We call it terminal restlessness. And it's kind of these almost like a delirium type symptoms. Some things to quickly look for, though, before you just automatically start treating, is make sure that they aren't constipated, they don't have a full bladder, impaction, infection. Look for some of those things before we automatically start medicating. So kind of look at how severe the agitation is. Is it mild to moderate? Then maybe we can just do some small interventions. If it's more severe, we may need to look at giving them some diazepams or other medications such as Haldol to calm them down. Think about urinary and fecal incontinence. Make sure we have the pads available, that we're doing good skin care up until the end, as long as it's not uncomfortable for them. And then skin integrity. Making sure that we're still positioning and turning if it's not uncomfortable. If it is uncomfortable or you see the patient grimace, then if they are actively dying, it's not the time that we want to be turning and be so concerned about skin integrity. But keeping the skin clean and dry is always important. And then teaching the family what they can do. Sometimes just showing them, how to put lotion on, things like that, touching them. And although it may seem common sense to us, we sometimes have to teach families that it's okay to do that. One of the things that happens pretty frequently at the end of life is dyspnea, or that shortness of breath. Think about what might be causing it. But for the most part, it's general comfort measures, positioning, elevating the head of the bed can help, opening up a window or putting the fan there to get the air moving, because sometimes it can be pretty stuffy. Of course, if they're on IV fluids and they're actively dying, we hopefully can discontinue those. Continue to do your physical assessment to distinguish the Cheyne-Stokes and apnea, which are part of the normal dying process, and this doesn't require treatment. So with the Cheyne-Stokes breathing, they may take a couple breaths and then there may be a pause, and that pause can be several seconds, 5 seconds, 30 seconds, and they can be variable, and this is all part that they're progressing through the dying process. If the dyspnea seems severe, we can treat that with morphine, typically, depending on what we think is causing the dyspnea. Noisy respirations is that respiratory congestion, or sometimes called the death rattle, but once again, we don't want to use that term with families. Using the term noisy respirations is better. And this happens in about a little over half patients at the end of life. And many times it's because they just can't clear the secretions. And really, the literature does suggest that these noisy respirations may be a good indicator, a predictor of that death is near. And usually the onset from the time from the noisy respirations was about 16 hours. So it's kind of an indicator that things are progressing. And then I just briefly wanted to mention PTSD. We talked about this briefly in the Veterans module, but sometimes PTSD may not manifest itself until the very end of life, and it could be manifested as this agitation or terminal restlessness. So once again, this is where we need to bring in our chaplain or physician to get medications if needed, or maybe even the chaplain to work through some forgiveness issues, depending on how alert and oriented the patient is. But many times it may just be that we need to medicate them, especially, like I said, if they're in a place that's very uncomfortable and is causing them to be very upset. There are several interventions at the time of death that we need to, so once the patient has gone through all the previous signs and symptoms and they've progressed and they're dying, things that we need to make sure, of course, that we do are assess, document, and educate the families on the expected signs and symptoms of dying. We had talked about some of these previously. The physical changes that begin to happen as death is approaching, the blood pressure decreases, body temperature can fluctuate. I talked about fever being common. There may be increased perspiration, meaning that their skin feels kind of clammy. That skin color changes. They can be kind of, if they have a fever, they can have a flushed appearance. If they're cool, they can have a bluish appearance. But kind of this pale yellowish color sometimes begins as they begin to approach death. So kind of variable per patient. The breathing changes we talked about. The arms and the legs may become cool to touch. So you touch their feet and they're really cold. And they may be, sometimes depending on the person's color of skin, they may have a kind of purplish color. And the knees, ankles, and elbows are kind of these blotchy colors. That's all because the body's shunting all the blood to the central area, the vital organs, in a last-ditch effort at life. So it's kind of shutting off the periphery, basically. And then because the muscle sphincters relax, that's what causes the bowel and bladder incontinence. And then as they die, the pupils become fixed, and of course they're no longer responsive to stimuli. So make sure that part of what we're doing is reassuring. Those are the physical symptoms. So what we're doing is we're reassuring the family that we're doing everything possible to keep them comfortable and that they're doing good work. Make sure that we're doing everything we can to make sure they're comfortable, that we're providing the patient and the family with the opportunity to review special experiences or memories in their life. We call this life review. So talking about who they are, what they did, those are things that you can really encourage family members to do during, if they haven't done it previously, during those final days, is to talk about them. Tell me what it was like during the war. Tell me what it was like growing up on the farm. What was important to you. So it gives them a chance to tell their story. Also allow the family to express their feelings. For example, we'll miss him so much. We feel sorry we couldn't save him. Those things. Provide information that the family requests and be honest with the information that you provide. Make sure that we're respecting the emotional needs of the family, especially children, and even family members who may need respites from the dying patient. Some people may feel that they need to sit vigil at the bedside, but allowing them permission that it's okay to step away from the bedside, because sometimes what happens is they sit there and sit there and sit there, and the minute they leave, that's when the person dies. And then once again, that's when you have to have that conversation of maybe that's when they chose to die. They choose when they're going to die. So helping them not to feel guilty about the person dying the minute they step away. And then allowing the family to stay with the patient once they do die. Allow them to stay with the patient as long as they wish. And then, of course, providing practical help. And by that, I mean practical help that's going to help them work through their feelings, help them to collect the belongings, arranging for helping with bereavement type issues, working with the social worker on what comes next, spiritual support. So once the patient has died, we need to think about mortem care, post-mortem care. Post-mortem care, of course, is initially the signs and symptoms that the death has occurred, of course. Confirm the occurrence out loud, basically saying she has died, she's gone, those things, so the family knows that the death has actually occurred. And that, of course, they stop breathing, there's no longer a heartbeat, all of those things that happen. Sometimes there'll be a little bit of a sigh, and then you don't hear any more breaths. So know what your protocol is for your facility on documentation, if it's an inpatient or you have a protocol, or if it's a hospice and the patient dies at home, there's a protocol for what should happen next. Think about cleansing the body, dentures, removing tubes, covering any wounds. Once again, there's a big cultural experience here. Remove medical equipment from the room. Make sure that we facilitate any cultural or religious rituals desired by the family. Encourage the family to spend as much time as they need to with a person in order to say goodbye. And then prepare the family for the removal of the body if it's going to be removed or what's going to happen next. And then, of course, follow your protocols. Make sure that you refer to the patient by name, discussing memories with the families, however the family wants to. Maybe there's silence there, or maybe they want to talk, emphasizing to them that yes, it is painful, maybe giving them a hug, whatever your comfort level is, depending on how well you know the family. And then I did want to discuss some cultural considerations. As you see here, I have quite a few different things listed, but once again, this is just the tip of the iceberg, and some that I thought were maybe common depending on where you work or where you're located. So I just wanted to discuss a few of these because it's really important that we understand some of the differences, because the rituals and customs really vary based on a person's faith background and or their culture. So I want to talk about Roman Catholic. If you have a Catholic patient, as many of you may have experienced, they typically will request to have the priest come in and do a sacrament of the sick, and the priest may hear confessions of the sins and absolve the individual. Many times they are buried in a Catholic cemetery, so just some things to be in tune with. The LDS, or the Latter-day Saints, the Mormon Church members, typically the members, if the same gender, are the ones that dress the person who has died, and the body is dressed in white undergarments. The man has a white cap and the woman has a white veil, very ceremonial. So just making sure that we do allow for this and that we understand that they have their own rituals. In Hindu, the Hindu priest would administer holy rites, which may include tying a thread around the head or the wrist of the dying person, sprinkling them with holy water, or even putting in a special leaf in the dying person's mouth. With a Hindu patient, and Hindus would be many of your patients of Indian descent from India, only another Hindu should touch the dead body. If you are going to touch the body, make sure that you are wearing gloves, which most of us pretty much do anyway, but make sure to leave all sacred objects such as jewelry and things like this on the body. Do not wash the body, as this part of the funeral practice is done by the family, and the body is washed with a mixture of yogurt and milk. Many times the adults are cremated while infants and children may be buried. So once again, if we're doing good palliative care, hopefully we've identified some of these things ahead of time. But unfortunately, many times, especially those of you in the hospital, don't have time to get to know your patients as well because it may be a different type of situation. With Muslim patients, they may wish to be facing Mecca. The belief is body belongs to God, so autopsies will be denied for the most part unless they're required or they're talked into a reason why they should have it. Organ donation and cremation are not acceptable. Non-Muslims should wear gloves when handling the body. Once again, do not wash the body because there's a ritual for washing the body, which includes 3 specific washes: a lotus bath, which is a flower, camphor bath, and then a plain bath. And many times they're buried in a shroud, a white kind of linen cotton type shroud, just part of the process. For our Jewish patients, they may want to hear or recite special prayers as they're dying. A relative usually remains with the dying person, as it's disrespectful to leave the body alone. Autopsies are typically not permitted, but organ transplant is. Orthodox are buried more often, while liberal Jews may select cremation. And once again, just like the others, the body is usually wrapped in a shawl, and there's usually not a wake or a viewing of the body. In the Buddhist religion, it's important to consider that the time of death, the state of mind is really important, so because it determines how they're going to come into their next life. Cremation is all right within the Buddhist religion. Death and burial can range to 3 to 7 days after the death. Burial can range from 3 to 7 days after the death, and the tradition is to wear white to the funeral, with the Buddhist funeral. Just a little tidbit on Cuban Americans. It's really based on their cultural backgrounds because there's various religions, but a good thing to know is many times you'll see large groups of family and friends at the bedside of the dying person. There's a religious ceremony, a religious sect called Santero, which could include things like animal sacrifices, ceremonial displays, and chanting at the bedside. African Americans, once again, depends upon, as with most of our cultures that we've talked about, is how many generations out are they? Is this somebody who was born and lived most of their life and then immigrated to the United States, or are they 3rd or 4th generation and maybe the ties aren't quite as strong? So as with any of the cultural considerations that I'm telling you about, it's just an overview, and of course we always have to look at the individual. So typically with our newer generation African Americans, they prefer to care for them at home but die in the hospital so as not to bring bad luck to the home. Mexican Americans may take standing vigil over the dying person. They do prefer to die at home and may have spiritual amulets, rosary beads, and religious artifacts at the bedside. And many times they'll keep altars at home after the person has died, which will have candles and decorations. And they may have different ceremonies at the grave site. Native Americans, of course, this varies according to tribe in general, because there's so many different tribes and different beliefs. But in general, some things, the belief that the spirit of the deceased remains where the death occurs, therefore they may not want to die at home. So it's important, if they do die at home, or those who are working with the dying person need to have a cleansing done. There's typically not usually embalming, and they're buried with their shoes on the wrong feet, with rings on the index fingers, with many gifts surrounding them. I've actually been to a couple Native American cemeteries, and from seeing the grave sites you can see there's many kinds of little gifts around the graves. Very interesting. In the Appalachian area, death is a very important event, and visitors will come from far distances to attend the funeral. So the bodies could be displayed for long periods of time, and many times people will be buried in their very best clothes or even have clothes custom made just for their burial. The Hmong are subgroups from China, Vietnam, Laos, Thailand, and Burma. And they believe that burial reflects directly on safety, on the safety, health, and prosperity of the family. So they generally prefer to die at home so the spirit doesn't end up wandering. Although some may prefer to die at the hospital so as not to bring bad luck into the home. So kind of one of those things, again, that's kind of individual. Chinese, they may place a coin in the mouth for anyone, to pay for anyone who might interfere with their journey into their next life. They may symbolically burn paper houses, cars, things like that. And sometimes it's acceptable for the Chinese to store a body so that the husband and wife could be buried together. Within the Japanese culture, they do bathe the dead. They may shave some hair and will dress the person in white. Favorite items sometimes are placed in the coffin. Within the Korean population, same thing with the body wash, but they maybe use perfume. They tie the clothes in 7 places to correlate with the 7 stars of Ursa Major constellation. And then last of all, Wiccan, pagan, and natural spiritualists. And just important to know that depending on what they are, this is one of those situations where we just have to ask. They may need to include their priests, priestesses, and death midwives might also be included in the dying process. So as you see here on the bottom right, I have a picture of an anointing, and then at the top shows an example of a Mexican American, just a vigil with candles and different ceremonial items. Typically after someone dies, there is a post-death follow-up if they've died on hospice care. Depending on if they die in your in-service palliative care unit, depending on how good your bereavement service is, I'm not sure if you have a coordinated process for that. But in hospice, there is a coordinated process, and typically cards are sent out to the family members, and they may be signed by members of the team as a bereavement condolence type card. Bereavement support is offered as long as they need it after the death to the family members. And then surveys are sent out typically the surveys most hospices use are from the National Hospice and Palliative Care Organization, and they're called the FEHC, F-E-H-C, Family Evaluation of Hospice Care, and that's a standardized survey. There's several different surveys. There's the FEHC-V, which is the Family Evaluation of Hospice Care specific to veterans. There's FEPC, which is the Family Evaluation of Palliative Care. And then there's the FEBC, Family Evaluation of Bereavement Care. So you see there's several different surveys. And the nice things about these is it really gives the hospice an idea of quality measures, because of course that's one of the things that everything is being measured against now. So that's pretty much the end. We'll end with the